presentation thinking about health inequalities, particularly from those that are not diagnosed. So I work with Ghazala on workstream 1.3. I hope you can hear me okay. I've got a blocked ear. I've got swimmer's ear, so I don't know how loud or quiet I am, so I apologise for that. So one of the sort of rationales behind 1.3 really is around understanding the experiences of people who have limited access or poorer outcomes in relation to long COVID, or people who are living with persistent symptoms of long COVID but are not being seen by clinics, haven't received that diagnosis. So we're focusing specifically on people from prime or the sort of classically underserved communities, so sort of socioeconomically deprived, ethnic minorities, homeless, traveller, and also groups with disability. We've got a good sample in terms of geographic spread across north and south of England, Wales, Scotland, and thank you to those who sent people our way, really appreciate that. We didn't quite hit the 30 for our sort of high-risk underserved communities. We've got 23, and within that, sadly, we weren't able to interview anybody from the homeless community, which was particularly challenging to recruit to. But we did speak to outreach GPs and outreach paramedics that work specifically within that community. So we have quite a good bit of data about that. We also got feedback from your lovely selves on quality improvement initiatives, particularly around inclusion, and the workshop that I'll be doing will be kind of delving into some of that in a bit more detail. So where we are now is really up to sort of looking at the data and unpacking what some of the issues are and writing up, of course. So a lot of this is not going to necessarily be very new to you, and you probably heard me talking about it before at the QIC event as well. So there isn't much more to say in terms of what I haven't said before, but I will just very quickly go through what some of the barriers have been, what some of the impacts, attitudes, etc. So I think some of the key issues, we know that this is an issue, is what happens at primary care. Why is it that people are presenting with various symptoms but they're not getting that diagnosis? And that kind of mimics Dennis's graph, this sort of tailing off of diagnoses. So, a lot of respondents felt that they weren't being heard. They were going to the GP, they were saying, got all of these issues going on, and that the GPs weren't necessarily linking it together and calling it long COVID. So I know we talked about this in this morning's session, that there are issues around education around long COVID that we need to tackle. And not only did they feel they weren't heard, they were also given what they felt was inadequate advice. And we saw also in the PAG video this morning, things like, oh, go and take some paracetamol, go and take some ibuprofen, you'll be all right. This kind of sense of dismissing people's experiences. This has been similarly reported in our cohort. What I want to stress, though, is what's different about the groups that we're talking to is that they are experiencing multiple forms of disadvantage. Okay, and we know from the LC statistics that it's predominantly white, middle-aged, often fairly affluent, articulate, educated people that are getting the long COVID diagnosis. People who perhaps English isn't their first language, or are deprived, or have issues around access more broadly. For them, they are not being heard. So there's a real issue around, people not being seen as whole. And, it doesn't take a lot to take that step to thinking, well, is there a kind of discrimination going on here? And in fact, many people in our questionnaires did talk about discrimination, both experience but also the fear of discrimination, and that was actually preventing people from going to their GPs because they were worried that, oh well, you know, I've seen people being treated differently. I've seen the receptionists use people's first names, but they don't use my first name, or you know, what have you. So the sense that you know, that they're just not sure, and I think this, particularly around racial discrimination, is the question that you just never quite know. You never quite know if people are treating you differently because of the colour of your skin and your ethnicity. So this kind of not knowing is actually further compounded with long COVID because of the raft of symptoms that people are experiencing. So you've got, well, I don't know whether I'm being treated differently because of the way I look or my background. I don't know whether I have got long COVID because I've got all these multiple symptoms, so I can't quite work out what's happening. And then also this sort of lack of trust as well. Well, you know, and I don't really know whether the advice I'm going to get is actually going to be useful, helpful, or will support me. So there's been a lot of barriers around that. Now, of course, those barriers also lead to impacts. And we've talked about work, and there's been a lot that's been said about work today. Within our cohort, 11 was still working. And again, this is something about the cohort that we're looking at, that a lot of people just have not been able to stop working. They're not working in professions where they will get sick leave. They are quite often self-employed and therefore are dependent on that income, so they have to keep on going. And this was a really strong message that came out in our data. Not only, you know, obviously the physical impacts, but also this thing about not knowing, well, I don't really know what it is that's wrong with me. So living in this kind of liminal state of sort of not really knowing, you know I'm ill, I know I'm not right, but I don't really know what it is, not being able to pinpoint it. And people talked as a result of emotional and psychological impacts. Again, it's that, well, you know, I don't really know what's going on. And it's really scary when you've got all of these symptoms and they've just come out of nowhere. And you know, people talking about how their lives have been put on hold. You know, within, I'm a medical anthropologist by training. And, you know, one of the things that we talk about is this kind of biographic disruption, where your life is kind of sort of stopped suddenly because of a particular condition. So there's been an impact on things like family life and social roles as a result. Attitudes. So again, this question of confusion around symptomatology, particularly at primary care, but also in terms of, you know, patients themselves having symptoms, not really knowing that they are long COVID. So one of those issues in terms of getting that diagnosis, well, if you don't know that you've got long COVID, it's very difficult to then go to the GP and say, look, I think it's long COVID. And one of the things that we've seen, you know, in other cohorts is that there is quite a sense of knowing what long COVID is. And I think what's happened, particularly within our cohorts, is that's not necessarily always the case. That a kind of awareness of the condition perhaps isn't necessarily there. People also have gone out and done their own research into long COVID. They might have a family member working within the health service, and it's through that family member that they come to understand what long COVID is, and then they've gone to the GP and said, look, I think it might be long COVID. But some of the sort of attitudes around people living with long COVID that aren't diagnosed that come out are things like, well, you know, not feeling eligible enough, or, you know, which is quite, you know, this is quite a troubling one, you know, and well, I don't, you know, my symptoms aren't debilitating, but I know something's not right. I don't want to be a burden, I don't want to go, and I don't want to, you know, put added stress onto GPs. Like I mentioned, people going and seeking support from elsewhere. or finding out more information about long COVID from different sources. And then actually people just really quite fed up. And I know that Claire, recognises that sentiment of, well, I've just been waiting for ages, I got a referral, I haven't been to the clinic, I'm being passed back and forth, this sense of feeling like a guinea pig. But the main issue really, of course, is access to GPs and access to primary care. This persistent self-advocacy is really draining on a lot of the people that we've spoken to, and a lot of the kind of psychological and emotional distress has come about through this having to constantly advocate for yourself and not having the time or the capacity to do that, because you may have a family or you may need to work, etc., particularly if you are a primary breadwinner. So waiting for ages on the phone, phoning at 8 o'clock, being number 25 in the queue, and then you get to number 1 and then the phone drops out. So lots of stories about that kind of thing. There's people's changing work patterns. Again, Rory's talked a lot about this. And then also ideas for change. And I think what I want to do in the workshop is sort of focus on what's come out in terms of good practice, but also some of the suggestions for change. So in terms of our KIs or key informants, so these are clinical academics, leaders in the third sector, working with people with long COVID. These are yourselves. I know I've interviewed a few of you in the room, etc. And some of the things that have come out obviously are, it's a story that we know. So we know who it is who's getting diagnosed. We know there is a low representation of marginalised groups, and particularly ethnic minorities, and that's evident in the LROS data itself. We know that there is likely to be a hidden cohort of sufferers out there, and our data is suggesting that they are multiply disadvantaged, and that perhaps is part of the reason why. I think one of the things that's coming out is we perhaps need to do more around looking at the social determinants of health and how that feeds into long COVID. At the moment, the picture is a bit murky. The data sets that we have don't particularly record things like deprivation terribly well. There isn't enough kind of perhaps nuance around ethnicity in the way in which we actually record data of primary and secondary care. So there are some kind of issues around that. We can't see a full picture unless we ask the right questions. So we need to consider what those questions are. Obviously these challenges again around primary care. We are seeing some really good practice come out, and thank you all for contributing to the paper that we are writing at the moment about what that good practice is. We've got leads looking at alternative referral pathways that we've talked about multidisciplinary teams, and people have fed in on that, which has been great. So, and I'll talk a bit more about that towards the end. But in terms of where we are now, we're kind of starting to analyse the data, and one of the things that's really coming out very strongly is this idea of a diagnostic odyssey. That people who are trying to get a long COVID diagnosis are sort of forever having to that journey to get that diagnosis is incredibly challenging for people. So the idea again of the sort of embodied biographic disruption as well is also coming out. I'm a social scientist, so we like all these sorts of terms. But there's a big thing around the lack of long COVID knowledge, frustration, not knowing where to go for support, this sense of liminality, which is a concept we use in anthropology quite a lot to describe that space in between when you don't know really what it is that's wrong, and you're waiting to kind of find out, so you're stuck in this kind of middle grey zone, which causes a lot of issues for people. But I think one of the key kind of issues around that liminality is that it really is kind of causative of emotional distress. It causes emotional distress, which when you couple that with intersecting multiple inequalities, you know, you get a kind of compounding of anxiety and frustration. What's also quite interesting is for the people that we spoke to who got COVID in the first wave and have had symptoms since then, that they really felt that, oh, I can't blame primary care. I can't be angry with primary care because they don't know themselves. So this real sense of sympathy, I think, really, with health workers and primary care. But then, of course, others, you know, feeling increasingly more frustrated and not being able to get the support that they need. So some of the kind of key concepts that we're exploring in relation to our data are questions around validation and the importance of people to feel that their symptoms are recognised, that they are seen, that they are held, you know, that their biography around long COVID is understood, is captured, and that there's a kind of authenticity to that relationship. And indeed a kind of legitimacy. Oh, I am ill because of this, and this is why, and it makes sense now. So those kinds of things are really, really important. So from the lovely clinics that we have as part of LOCOMOTION, we have had some data back from yourselves around inequalities. So again, it's that same picture of the underrepresentation of deprived groups. We've seen a sort of lack of inclusion of homeless, people with learning disabilities, migrant, traveller communities, underrepresentation around ethnicity, you know, and this has sort of come through from a lot of sites as well. We have some kind of interesting data, so ONS data is largely self-reported data, as you know, but there are some larger studies that are looking at the symptoms and are looking at sort of GP referrals and what have you. They're starting to kind of generate a bit more interesting data around ethnicity. Again, gender and age, it's the same picture that we've been talking about, and obviously in terms of, I think it was Salford, came back saying that a lot of people are professionals, they're skilled workers. So some of the good practice that we've have reported back around sort of identifying and prioritising particular communities and groups and tailoring services to meet their needs as far as possible, and that can be around sort of digital literacy, for example, and what have you. GPs, we've heard of symptoms training. I think somebody mentioned that they've been out training GPs on long COVID, also targeting particular communities and third sector involvement in long COVID referrals and navigating support for excluded groups. Again, this idea of reaching out, and perhaps the clinic as a space that can reach out into the community more, utilising influencers within the community to help raise awareness of long COVID. Diverse clinic sites as well, which is really interesting. You know, like for example, within Leeds, there are kind of multiple sites around the city, and I think that has really sort of come out as being quite a good way of running things. Finance capacity is obviously a really big issue, and offering sort of different and alternative forms of assessments and visits has also been quite useful. I think home visits could be particularly so for people that might have mobility issues or transport issues. So one of the things obviously that has come back as a negative is sort of thing around fragmented treatment plans. So seeing that sort of multidisciplinary, multi-sector teams can help to create more sort of unified plans for people, tailored care pathways, holistic support, reducing the adverse impact of referrals to clinic, with long waiting lists for groups with high levels of existing ill health, to balance new patients with existing cohorts as well. So that thing of understanding, well, you know, who is it who's being seen, and how does the data around new cohorts compare to old cohorts, and what's the kind of gaps in between. Stuff around comorbidities and self-management, and how people can sort of learn how to kind of manage or self-manage particular comorbidities. Flexibility as well has really come out as being kind of key. So being able to kind of reflexively and flexibly respond to people's needs, and that's been really evidenced in what we've talked about. And this idea of the evolving service, again, which Trish talked about earlier, and this idea of, you know, it's trial and error, you know, we are trying to work it out as we go, and within that comes this evolving service. And I just want to quickly talk a bit about peer support, if I can, add that in. So I didn't do the interviews for the peer support research, but one of the things that we're wanting to look at is whether the models of peer support that we explored in the literature review are actually operational on the ground for people, and what kind of models are going to work best. So there's some really interesting data that's been gathered around that, and particularly thinking about how to kind of include more excluded groups. So co-design, for example, offering flexible service, involving participants directly in their own care, giving that kind of metacognition and ownership over the process is really important. Understanding cultural and historical experiences of groups such as diasporas, but also those kind of historical experiences of healthcare themselves. And I think, you know, that's quite an important issue. Making sure that programs take into account intersectionality and different social determinants of health, and how they interact with each other for particular communities as well. And power relations within a setting, really important to address.